is Dr. Bilal Bobat. Dr. Bilal Bobat is a hepatologist and gastroenterologist at the Gordon Medical Center and involved in the liver transplant program at the Gordon Medical Center. He's fondly known as Dr. Billy Ruben Bobat in the Gordon Medical Center. And he comes with a wealth of experience, a fantastic sense of humor, but also a fantastic degree of care and love for his patients and his profession. So we welcome Dr. Bobat to give us a talk on what's eating your liver or what's happening in your collagen.
Jazakallah, Shoaib, for that. I want to specifically just thank the organizers of the meeting for a very well laid out program. It's been fantastic thus far, and especially for bringing down Sheikh Hassim Yusuf back to South Africa. He was with me at medical school, and it's just fantastic seeing him again and enjoying the conversation. So I've been given this somewhat broad topic of what's eating your liver, grease, genes, and germs. And I'm going to try and quickly go through a couple of the points regarding each. Specifically, though, I'm going to be focusing on the topic of metabolic-associated steatotic liver disease. So, metabolic-associated steatotic liver disease, or MASLD, is the liver manifestation of the metabolic syndrome, and at its heart, as Dr. Hanneke pointed out, is insulin resistance. If you look, you have your various components, hyperlipidemia, obesity, diabetes, hypertension, steatosis, all of which can give rise to malignancy, both extrahepatic and hepatocellular carcinoma. Your diabetes obviously can, result in your chronic kidney disease, nephropathy as one of the target organ complications. But this just tends to make these patients, when they present for things such as liver transplant, that much more complex and more difficult to manage, because this is still a multi-systemic disease. This isn't a disease specifically of the liver. MASLD is growing. Globally, you've got about 436 million individuals with type 2 diabetes, and of that, about 65% of individuals with type 2 diabetes have some degree of MASLD. Thankfully, not necessarily that sort of number have MASH, which is the steatohepatitis component, the inflammatory component that leads to fibrosis and hepatitis. So, just looking at how things are annually increasing, in most countries it's about a 1%, anything from 1 to 1.4% increase, and that is gradually accelerating over time. And most certainly, ultra-processed foods are a certain component of that. Your industrial food complex is not out to look after your health, it's out for profit. And the profit is you buying more and consuming more, never mind about your health. Right? So this is gradually increasing, and you can see that some of your fastest growing areas for MASLD, sorry, I just need to reach over, but your Asia, your area is not really necessarily associated with all that much alcohol consumption, which was considered to be the hallmark of steatotic liver disease previously. MASLD itself has actually was only recognized in the early 1980s as a condition on its own. It's now the second most common cause of liver transplantation in the world. It's overtaken viral hepatitis C. In terms of its pathogenesis, there are genetic aspects, there are specific genes associated with the development of insulin resistance. Your South African, and I'm not sure, is Aslam here yet? I know he's up next, but he'll probably tell you that the South African Indian community, Dr. Randy may even attest to this, but the South African Indian community has one of the highest prevalences of type 2 diabetes in the world. And part of this is due to some of these genetic issues around PNPLA, TN6SF2, MBOT, and a number of other genes that have recently been identified. There's a complex interplay between the brain, the hormonal milieu, and appetite. Then you go to the gut, and Dr. Haneke spoke about your gut dysbiosis, whether your pathogen and damage-associated molecular patterns which stimulate inflammation are released and washed into the liver, where they incite inflammatory reactions, both upregulating and downregulating inflammation. The actual effect of the adipose tissue and its effect as an inflammatory organ in itself, which results in further inflammatory cytokines being released into the liver. All of this then results in some of those free fatty acids in predisposed individuals, and those predisposed individuals can be depending on your gut microbiome, on whether or not you're consuming alcohol at the same time, whether you have viral hepatitis concomitantly, but then also other conditions, psoriasis. Psoriasis and both dermatological manifestations and psoriatic arthritis are intrinsically linked to fatty liver disease because they share similar inflammatory pathways. So if you've got a little bit of metabolic syndrome and psoriasis, those are patients that really should be screened for the development of fatty liver disease. The lipotoxicity then stimulates your Kupffer cells, which result in a pro-inflammatory cascade that eventually results in fibrosis over many years. Your diagnostic criteria then: do you have steatotic liver disease, either identified by imaging or biopsy? Just a simple sonar could be enough, and a quick rapid way of doing this is comparing what does the liver look like compared to this kidney. Your right kidney is just next door to your liver, and you can contrast that imaging quite nicely to say, yes, there is a degree of increased echogeneity of the liver suggesting steatosis. Does the patient then meet any of your cardiometabolic criteria? And that, to the side of the screen there, would depend on what their BMI is. Fasting serum glucose, I often look at their fasting insulin level if they are not a diabetic. What's their blood pressure, plasma triglycerides greater than 1.7 millimole, and plasma HDL and LDL. You then ask, does the patient consume alcohol? And if they're consuming alcohol then, and it's anything more than 20 grams of alcohol for a woman and 30 grams of alcohol per day for a male, that equates essentially to 2 units for women and 3 units for men, which is still somewhat significant. You'd consider that then to be something called MET-ALD, or metabolic plus alcohol-associated liver disease. Here's a picture that we commonly take in our clinic. You can see that the liver's looking a little bit brighter than the kidney just next to it. And then your question is this metabolic-associated liver disease, or is this alcohol-associated liver disease? And one of your next clues that I look at is you look at the gamma-glutamyl transferase, ALT and AST. In MASLD, or MASH, in the case of this individual at the top of the screen, you'll see that the AST is approximately half of what... Mohammed, you walked straight past over my slide. Okay, so ALT is double your AST in metabolic associated steatotic liver disease, but in ASH, and this is someone now with an active alcohol-induced hepatitis, you'll see that your AST is actually twice your ALT. So that's one of your big clues in terms of figuring it out. And this is someone that's quite ill. You can see with that total bilirubin sitting at 270. In fact, no, even more than that. I cut off the total bilirubin. So that's someone that was ill. Your patient that may present to you in general practice may only have an elevated gamma, elevated AST, elevated ALT. So this is your algorithm then for the classification of your steatotic liver disease. If you've got components of the metabolic syndrome plus a fatty liver, you probably have MASH. Not mashed potato, MASH, right? Your Met ALD then is when you're sprinkling alcohol on top of that, right? And then if their consumption is significant, more than 5 units per day of alcohol, that's probably more alcohol-associated liver disease straight out. There are other causes of fatty liver, including drugs. I see, some of the psychiatrists are in attendance, and some of those medications both will increase your weight, but can also affect your metabolism and increase insulin resistance, but also just from a direct drug effect, you can get a degree of fatty liver. That doesn't necessarily mean that you've got MASH. Oncology, tamoxifen is one of the commonest causes that I see in clinic for women developing fatty liver, and this fatty liver, especially when combined with metabolic associated steatotic liver disease, can be quite aggressive. You can switch from a relatively benign MASL phenotype to the more aggressive MASH phenotype with the addition of something like tamoxifen. You then have monogenetic disorders, Wilson's disease being the archetype for that. Hepatitis C virus will cause steatosis. It induces insulin resistance by itself. HIV similarly, and then straight up malnutrition and celiac disease on the other end of the spectrum. Your FIB4 is one of the most important factors for, if you take one thing out of this talk today, remember the FIB4. The FIB4 is your screening test for pretty much any form of chronic liver disease. It's not specific to metabolic associated liver disease. It can be used in other instances as well. And it's a good way of ranking whether or not your patient has advanced fibrosis or not. It's freely available on most medical calculators and is very easy to use. 4 things: your ALT, your AST, your platelets, and your age in order to calculate it. This is something published, I think it was in May, by the American Diabetes Association, and looking at the care of your diabetics. We're now moving beyond looking at your 10 Newton monofilament and thromboscopy, check the urine for proteinuria. You're now including the FIB4 as part of your standard of care for these patients. Is your FIB4 elevated, more than 1.3? If so, they need to go on to a higher level of screening, whether you're using other non-invasive tests, such as liver stiffness measurement by transient elastography. This is technology which it's becoming more commonplace. We've got one in our clinic that'll, the proprietary name is FibroScan, which will then risk stratify the patient in terms of where they sit with their fibrosis. If they sit at a low threshold, just repeat the test every year or every second year because they're still at risk, but don't necessarily need escalation up. Alcohol and MASL, the definition, yes, allows for moderate alcohol consumption. A glass or 2 a day, maybe over the weekend they'll have a glass or 2 of wine. Your information to them is going to be, no, you can't. It's haram, right? Here, in terms of your hazard ratio, you can see that if they're overweight and drinking above guidelines, they actually have an 8 times greater risk of liver-related mortality. In terms of management then, right, I generally insist on 6 months of lifestyle change. You can often correct this just by fixing up your lifestyle. You don't necessarily need to go to your high-powered drugs for this indication. That's not to say that the majority won't still need some form of therapy. Dietitian, I have patients that come and say, no, I'm making smoothies every day for the management of the diabetes, and that's probably not the best thing to be doing, right? Because you're actually taking away the work of digestion and you're taking in a large amount of fructose, right? Fructose consumption is what needs to be reduced specifically. Do your fibrosis assessment, whether it's by a simple FIB4 test or elastography, early on. Manage your comorbidities. Do you adjust your diabetes script, an SGLT2, a GLP-1? Make sure that they're vaccinated and make sure that they're on a statin. The misnomer that statins are bad for the liver is gladly being dispelled. Statins are very good for the liver. They prevent HCC, they prevent fibrosis progression. So don't be afraid of statins, just maybe a lower dose than what you were initially thinking. This is why I say most patients are going to probably need some form of pharmacotherapy or maybe an appointment with Ibrahim to try and achieve the weight loss that's required in order to reverse the metabolic syndrome. Only 10% of individuals can achieve the 10% plus required to lose weight, required to resolve the steatohepatitis and the fibrosis at 52 weeks. The rest end up yo-yoing, right? And that's where this whole new industry around your obesity management has come into place. And we do need to address the stigma associated with that. It is a chronic disease. It needs to be managed like you're going to be managing your hypertension, like you're going to be managing your blood pressure. Here's your chronic meds. This is going to be it. You can't go 6 months and then stop. Your lifestyle modification then, aerobic and resistance, and I emphasize resistance training to the patients. Your muscle is a metabolically active organ. It is not an inert push-pull-pulley system. Any form of diet, whether it be low-fat, low-carb, Mediterranean probably has the most evidence. Reduce your fructose intake and increase your coffee consumption. Coffee is good for you. More than 2 to 3 cups a day is what's recommended for liver health. It can be decaffeinated if you don't like the caffeine, but specifically coffee, and I don't mean Starbucks, right? You're not going to be putting syrups in, you're not going to be putting cream in, you're not going to be putting all of that, and you're not sending your money for the IDF by sending it to Starbucks, right? Benefits of exercise, right? Going on to therapies, semaglutide. Sorry, I'm rushing. There's a lot to speak about. The Essence trial came out at the end of last year. This was this was proof that the GLP-1s can actually reverse some of the fibrosis. And as you can see here, reduction in fibrosis and reduction in steatohepatitis. 2/3 of patients achieved reduction in steatohepatitis, and 1/3 of patients started pulling back the fibrotic building blocks that lead to cirrhosis by, I think it was 72 weeks. Stand to be corrected on the exact timeline. But that's looking very promising. Resmetirom, this is a new agent. This is a thyroid hormone receptor beta agonist. This is only found in the liver. So what they found was that when you have a lot of liver fat, you result in a state of relative hepatic hypothyroidism, which results in increased adiposity within the liver. Resmetirom has been shown to be to stimulate those particular receptors and has resulted in a reduction in fibrosis. It's still small numbers, but this is the only drug at the moment approved in North America and Europe, specifically for the management of fatty liver disease. That's not to say that the therapeutic pipeline isn't significant. There are so many drugs coming that, I wish they'd just make them easier to pronounce, because some of these are real tongue twisters. Sarcopenia though, right? When you're putting a patient on a GLP-1, and I think this is a big problem when it comes to individuals that go onto a GLP-1 for a brief period of time, 6 months or so, they will lose weight, but you need to remember that approximately 30% of the muscle of the mass that they lose is lean mass. That's your skeletal mass that you're trying to actually hold onto and protect. And if those patients go on for 6 months, they lose a significant amount of weight and then stop the GLP-1, they will pick up the weight very quickly, but they will not pick up the muscle, right, as easily. And that leaves them metabolically in a poorer position than when they started the drug. And that's why I say, if you're putting a patient on a GLP-1, the patient needs to know that this is going to be forever. And right now, those drugs are still very expensive. The good news is that semaglutide, I think the patent expires next year. I'm not sure if we're going to be getting any generic GLP-1s for some time. When it comes to sarcopenia, remember this is really it's becoming more and more important, especially in the, we've been on about it in the transplant setting about sarcopenic patients and what their longevity outcomes are and how to reverse sarcopenia. Once you hit the age of your late 30s, early 40s, if you're not actively defending your muscle mass, you're losing approximately 1% of your muscle mass per year. So if you think about it, when you hit your 60s, you've lost 20% of your muscle mass if you don't have any other insults along the way that may exacerbate it. Sarcopenia has been associated with increased risk of mortality in multiple good quality trials, increased risk of assisted living, increased risk of hospitalization, death rate in hospital. So it is something which we need to be aware of and we need to be protecting against. We can't have someone in their 30s or 40s going on a GLP-1 and losing all their muscle mass in that fashion. Of course, the medical industry is onto this, and Big Pharma have already come up with a myostatin inhibitor. It's a dual myostatin inhibitor and activin A, I think it is, activin type 2, sorry, a receptor blocker, which stops the muscle degradation. So this was presented at the ADA this year, and yeah, it's a monoclonal antibody, and I'm not entirely convinced that you want to be taking monoclonal antibodies to make yourself buff, right? But it does protect your lean mass somewhat successfully. FGF19, fibrosis growth factor 19 and 21, efruxifermin, like I said, they're coming up with these tongue twisters, right? This is the first drug to show cirrhosis reversal in NASH, and so there's a lot of excitement around this therapeutic target. Cirrhosis reversal is possible. I know a lot of us at med school were taught once you get cirrhosis, that's endpoint, finish, and cloud. I'll show you a slide around hepatitis B shortly. This is another exciting signal RNA molecules that are in phase 3. We're participating in the trial for your HSD 17 beta 63 molecule for alcohol-associated liver disease, which essentially you take the signal interfering molecule and it stops the transcription of that particular gene which stimulates the lipotoxicity and so on. And in alcohol, it's thought that this will improve their survival. So again, from the ADA, looking at management of these patients, your obesity pharmacotherapy, GLP-1s or dual therapies should be considered. Look at your pioglitazones and SGLT2s. I leave that for you to possibly reference at a later point because I'm running out of time, and I want to quickly chat about the germ aspect. Right? Germ warfare, A, B, C, D, E, know your viral heps. Hepatitis A and E is often foodborne, right? So you don't really have all that much protection. And at our liver unit, we saw a lot of patients from around the country coming in with both MASL and acute hepatitis A, and it presents in a syndrome called acute on chronic liver failure, which is devastating, has a very poor outcome generally. It results in multi-organ failure and intensive ICU support. This is something that is vaccine preventable. We are unfortunately sitting in a situation where we've had flooding, we've got municipal dysfunction. Just get yourself and your families vaccinated against hepatitis A. Put that as a priority. Your viral hepatitis B and C, then you can see quite a bit of overlap between the areas of high MASL prevalence and high viral hepatitis incidence. And these can interplay and aggravate each other. The fact that ultra-processed foods are often cheap and readily available, it's so easy to just pop off at McDonald's and buy a burger there rather than going home and making a home-cooked meal. And it's often even cheaper because of the fact that it's mass-produced, is why in low socioeconomic countries, obesity is actually increasing, and food insecurity is associated with that. So MASL and viral hepatitis B, the fat actually stimulates or inhibits rather, the immune system from clearing the hepatitis B. It elevates your HCC risk and you have worsening of your fibrosis. Both hepatitis C, the hepatitis C then aggravates your metabolic syndrome through various genetic pathways. The presence of either of which, with NASL, will accelerate you to NASH and cirrhosis. Hep B therapies, tenofovir, alaflutamide, has just been launched. In fact, you guys are hearing it first because the actual launch date is only on World Hepatitis Day at the end of this month. This is a far safer molecule than the tenofovir difumarate that we're all familiar with. Make sure that the latest Hep B guidelines have came out at last year and lowers the threshold quite considerably for the treatment of hepatitis B. Hepatitis B then, yes, you can use your FLIP4, but the better one would be the ACRE score. Treat all with Hep B DNA more than 2,000 and ALT upper limit of normal, or even if you've just got an elevated ALT, right? Treat the Hep B. Tenofovir is really the best option, and looking at pricing, this is one of the generic companies in combination, and it's only I think $260, which really isn't that bad, and it's superior in side effects. What I was talking about in terms of reversal of cirrhosis, this is a graphic illustration showing baseline therapy, and then after 5 years of tenofovir, you can see all that bright pink fibrosis just clearing up with resolution of fibrosis, never mind the reduction of their cancer risk. Mother-to-child transmission is really one of the cornerstones of transmission in South Africa, and we need to address this. Try and vaccinate your kids early. Put mothers with viral load more than 200,000 on therapy. Hepatitis C, I still got 20 seconds. Hepatitis C, we've got effective therapy. 95% with minimal monitoring. If you've got a patient with hepatitis C, check your drug interaction. Treat them with sofosbuvir, valpatisvir, it's the only drug we've got on the market, and 95% cure rate. Shukran for your attention. Time's up.
I'll give you another minute or two. I wasn't, just a signal. Jazakallah, as you can see, even though he's someone who likes liver regeneration, he delivered that lecture very well. And are there any questions for our Bilal, our Dr. Bobat? You guys know everything there is about the liver?
I just want to find out, is it appropriate that all fatty liver patients should be seen by a hepatologist, or who manages this?
There's only 6 hepatologists in the country, so you're not going to be able to necessarily get it, and hence that algorithm that I showed. Yes, you do kind of want to escalate their level of care from primary level to your specialist care once you've got an idea of advancing fibrosis, right? And in that instance, I would still say you've probably got more endocrinologists in the country. They need better control there, right? And you can still reverse that process, but once you start having full-blown cirrhosis, that needs to be either with a gastroenterologist with hepatology interest or a hepatologist that you can possibly get access to.
I mean, Bilal, how much does this FibroScan could it cost? Is it something that endocrine practitioner or general practitioner could invest in?
I think the actual device is very expensive. I think the new pricing's around the 2.5 million rand mark, which puts it out of the realm of single practitioners. Where you've got group practitioners, especially if there's a group endocrinology practice, a group rheumatology practice, a group hepatology practice, yes, I think that then becomes useful. This is really a device that will be for individuals with that specific hepatology interest. The medical aids are now starting to pay, not necessarily enough, I feel, to really say that it's going to be something that's profit driven, but it is going to give you information. So In Johannesburg, for instance, we've got a FibroScan at Donald Gordon. I'm not sure if there's one in Durban. I know that my colleague Niall Rojbali in Cape Town has a FibroScan there, but they are still few and far between.
So, I mean, from a South African hepatology perspective, can the six of you not get together and do a guideline document? Because this, as you said, it's a very common problem, and it's part of the broader metabolic syndrome paradigm. And if you're going to be looking at screening all diabetics for patients with metabolic syndrome, you want a simple, way to do it, and maybe a one-pager to give guidance to general practitioners and general physicians in terms of how to look for this and when to refer is appropriate. There's a question.
In an adult male Indian, no chronic illnesses, but early onset muscle. Should one be doing anything slightly overweight?
Yeah. Make sure that the lifestyle modifications are done, right? Specifically, especially in the male, you want him to try and get into a strength training program and put on muscle. If he's not diabetic already, your simple maneuvers such as the lifestyle measures may be enough. Obviously, that's a patient that you're then going to be following up and assessing. If it was a Caucasian individual with an alpha-1 antitrypsin gene defect, that may be slightly different, and you may want to go somewhat more aggressively. But your lifestyle measures to start, and then your FIB4 to guide you in terms of how you escalate management.
And how much, you've said we should eliminate or reduce fructose, but eating whole fruits, how much should we limit ourselves to?
So, there's a ranking on fruit, because, the other thing is that fruit isn't necessarily the fruit that we had 20, 30 years ago. If you look at, there's now candy floss grapes, right? Your grapes are sweeter, your apples are sweeter than they used to be, containing more and more sugar. So you just need to recognize that the amount of what's the amount of fructose that you're taking in, right? I said reduce, I didn't say eliminate. So I'd still encourage some whole fruit in the diet, but it's some, and be careful, choose the ones that have less fructose.
I think when it comes to whole fruit, the fiber makes a difference in terms of increasing the transit of the fructose and the absorption of it, from what my understanding. We've got some endocrinologists in the audience. I don't know if any of them want to comment. Do you guys routinely screen your patients for fatty liver, or like the rest of us, do you pick it up by accident?
So we generally
just a mic is coming.
Thanks, Shiv. Yeah, look, as endocrinologists, I think the majority of us routinely look for fatty liver disease. Blood markers aren't very accurate, so you can have normal liver function and still have fatty liver disease. So, and we all recognize that fatty liver disease is in fact one of the biggest precursors to diabetes. The important thing that the patient was just mentioned is that they may not appear to be diabetic, but you must do a glucose tolerance test actually, and do that at least every 2 years if the one that you do turns out to be normal. In terms of FIB4 and then proceeding with FibroScan, FibroScan is like 2 to 2.5 million, I think, for a machine. So, I've actually arranged with the company to have a machine at my premises for 1 week every 2 months, for example. It sort of gets around the cost issue, and so all of my patients that need a FIB-scan, FibroScan will come in. I'll put them in electively for that. But very under-recognized condition and very under-treated condition. I think that's important.
Okay, Bilal, Jazakallah, thank you very much. I think